Now, keep in mind, PE is technically under arterial disorders, so it's not on the circulatory chapter. Okay, again, this is chapter 26 under VTE, because most PEs are caused or preceded by a VTE. Although obviously not, you saw it in stroke, right? So a clot can form inside the heart chambers, and then which one would cause a stroke? Clot on the left or clot on the right side of the heart? Clot on the left will cause a stroke. Clot on the right side, though, can potentially cause a PE first. And if any clot makes it through the left side, then that can cause a stroke. Okay, so that explains why it's under chapter 26. Okay. So the first part is the review, VTE. I won't do the VTE. However, I will come back here because the risk factors are the same. Risk factors and the treatment is the same, technically, PE and DVT, because both are caused by a blood clot. And now obviously a VTE can cause a PE. But let's start with the risk factors. So who are at risk for a pulmonary embolism? Before I go any further, let me remind you, chapter 26 will only describe signs and symptoms and management of a PE caused by a blood clot. Are we clear? So this chapter does not mention anything about fat embolism, air embolism, or any other debris that can cause a pulmonary embolism. Because debris like a piece of a catheter, for instance, a piece of a foreign object can also cause a pulmonary embolism. Are we clear? Okay. So here are your risk factors. Basically, the varicose triad. So varicose triad are endothelial injury, hypercoagulability, and venous stasis. Okay. So these three conditions promote the formation of clot. So endothelial injury, any trauma done to a blood vessel. That blood vessel could be a capillary, a vein, or an artery. So surgery, trauma, all mentioned here, do they all injure a blood vessel?
Yes.
Yes. So when you injure a blood vessel, that triggers tissue factor to be released by the injured blood vessel, and that will promote the clotting cascade, right? So I hope you remember that from Dr. Farrington. So all these conditions cause a blood clot to form because you injured a blood vessel, and the blood vessel will release tissue factor, which again triggers the clotting cascade. Second is venous stasis. So venous stasis is any condition, cardiac or mobility. So we talked about mobility problems this morning, from Parkinson's to spinal cord injury, multiple sclerosis, ALS, Huntington's, right? So those conditions have some form of immobility. So any patient who has immobility or a cardiac problem, for instance, such as heart failure or atrial fibrillation, atrial flutter, causing blood to pool in one or more areas of the body. Doesn't matter where it pools inside the heart chambers, pools in the legs, pools in the arm, pools in the sacrum, doesn't matter. Venous stasis will lead to clot formation. Spinal cord injury is included here because why? Are these people moving? Okay, these are bed-bound patients. Obesity, they have decreased mobility as well. Okay. So altered coagulation, these are also called hypercoagulability, meaning various conditions, cancer or other conditions that lead to increased susceptibility to clot formation. So included here are smoking, you've got cancer, number one, oral contraceptive use, and then if you combine that OCP use plus smoking, that increases your risk factor. Polycythemia, because you have so much blood cells, not only red blood cells, but white blood cells and platelets, so much cells in your bloodstream, that's called polycythemia. That crowds the circulation, right? Promotes the formation of blood clots. Pregnancy, you now have double your circulation, correct? Because now you have you have to supply the growing placenta. And the placenta has its own blood supply, correct? So now double the blood volume, double the chance of a clot formation. Protein C and protein S, I don't know if you remember these, but these were talked about in DIC from your presentations last semester. So a deficiency in these two proteins, because they are important to prevent inappropriate clotting. So therefore, if you don't have enough of them, there will be inappropriate clotting. And septicemia obviously leads to sepsis, septic shock, and then DIC. All right. Again, I won't repeat the DBT. So the only reason I did that because the DBT and PE have shared the same risk factors. Then I'll come back here for the management. Okay, management is the same as DBT and PE. So let's go to PE first, and we'll come back to the management. So here is pulmonary embolism. Now, this is the obstruction of one or more pulmonary arteries by a blood clot. Now, in any other part of the body, let's review. In acute coronary syndromes, if this clot clogged or obstructed the coronary artery, what do you call it? If this same clot happened anywhere else in the body, for instance, in acute coronary syndromes, if this clot obstructed a coronary artery, what happens? No, we just talked about this in, for exam 2. An MI, right? Yeah, so this is an infarction. Yeah, this is an infarction. And then 2 weeks ago, if this clot obstructed a carotid or cerebral artery, what do you call it? Which is cerebral infarction, right? Both were called infarctions. Why is this not called an infarction? It's the same obstruction by a clot of one or more pulmonary arteries, but yet there is no infarction here. It's called a pulmonary embolism. Why doesn't the lung tissue die with this obstruction? No, it obstructed. See, same obstruction of a pulmonary artery or one of its branches. Why did this not result in an infarction? 2 reasons. One, there are several branches of the pulmonary artery. So if one is blocked, you can simply go to another side. Plus, if you think about it, is the pulmonary artery really supplying oxygen to the lung tissue? Is it? What kind of blood is passing through the pulmonary arteries? They do not carry oxygen. So therefore, is that blood vessel perfusing the lung tissue?
No.
It is not. So therefore, the lung tissue does not depend on the pulmonary arteries for oxygen delivery. It is supplied by the bronchial arteries. So the bronchial arteries branch off the descending aorta, and those are the two. Left and right bronchial arteries are the ones supplying blood and oxygen to the lung tissue. Are we clear? So that's why this is not called a pulmonary infarction. Can a pulmonary infarction occur? Yes, but it's extremely rare, right? Yes, it can occur, but it's unheard of. Okay, so very rare if you get a pulmonary infarction. Probably the most unlucky person in the world. PEs though are very, very common. Is probably the top cause of death in hospitalized patients. Those that just die so spontaneously, you were especially on a non-telemetry floor. Let's say you're on a med surge, nobody's on telemetry, you walk into your patient's room during your routine rounds, they're dead. Okay? And they've been dead for possibly 30, 45 minutes. Okay, so it happened in between your rounds, right? Because especially, when you're busy, right? You're seeing other patients and then you make your rounds, make sure people are alive, right? So that's one of the reasons I never like working on a regular med-surg floor, because I don't know if my patients are alive. I literally have to walk in and watch the patient breathe to make sure they're alive, right? Unlike in telemetry, they're on a monitor. So my monitor tech knows and can tell me if my patient's dead or not, right?
That means you're lazy.
Well, I wouldn't say that. Again, going back to med-surg. Okay?
Yeah, the first one.
So in med-surg, you have what?
This is about manual work, right? You have to do
In med-surg, you have 1:6 or 1:8 patient ratio. Okay? You can get busy. Okay. All right. So PE is again usually caused by a clot somewhere else in the leg, for instance, or elsewhere in the body, and then the clot ends up the clot ends up in one or more branches of the pulmonary artery. As I mentioned, there are other types of emboli: air, fat, amniotic fluid, and septic or even foreign bodies. Again, the chapter 26 discusses which type, the one caused by a blood clot only. Okay, so that's what we're discussing and testing for next week. So when this happens, there is now obstruction or one or more branches of the pulmonary arteries. So therefore, whichever sections of the lung those pulmonary arteries are supposed to supply, is there gas exchange occurring there? No, there's no gas exchange, meaning blood went to other places of the lung, but those blocked areas where there is a clot obstructing, can blood reach that section
No.
and perform gas exchange? No. So therefore, some blood went to the lungs, but came back empty-handed when they returned to the left side of the heart. Are we clear? So what's the overall result? Low oxygen. So that's the main problem here. So it impairs gas exchange. It impairs oxygenation. Do they kill lung tissue? No, because again, the lungs do not depend on the pulmonary arteries. There's no infarction here. Now, depending on the severity, because there are 3 categories of a PE. There is low risk PE. There's also a submassive PE, and then there's a massive PE. Okay. The manifestations vary depending on which category the patient has, and therefore treatment will also vary depending on the severity. Okay. Let's do the symptoms. Symptoms again vary with each category. So these are the symptoms. Not all patients will have dyspnea. For low risk PE, the patient may have some mild dyspnea, but all 3 will report a sense of impending doom. What does that mean? Severe anxiety. Yeah, they feel like, oh, something's not right. Hey, see, something's not right. Something's wrong. I'm gonna die.
Yeah.
All right. They all feel like that. So dyspnea, most common symptom. Chest pain. Usually chest pain is for submassive PE, and definitely there's chest pain in massive PE. The key here is the symptoms begin with acute onset. They were fine a few seconds ago, and then now they have the symptoms suddenly, which resembles what's happening, correct? Because a clot suddenly obstructed the one or more branches of the pulmonary artery. So these are the other manifestations. So besides the dyspnea, chest pain, patient will have anxiety, like I said, or you can say apprehension. And then once oxygen drops, what's automatically triggered? Increased heart rate, right? And then increased respiratory rate. And not all, but some patients will have hemoptysis, blood-tinged sputum. There's a cough, and then syncope, typically once the oxygen levels are severely impaired and the patient will faint. Most frequent early sign is increased respiratory rate, obviously, because the oxygen levels drop. Once suspected, the patient will be sent for the blood tests will be D-dimer. But of course, are the manifestations, let's go look at the manifestations. Are these exclusive to PE?
No.
Or can you see these in other conditions as well?
Yes.
Could this be a heart attack?
Yes.
Could this be heart failure?
Yes.
Could this be COPD exacerbation?
Yes.
Could this be an asthma exacerbation? Yeah, they resemble, right? I mean, a number of causes can trigger respiratory rate increase, correct?
Yes.
So therefore, will the doctor order one test at a time?
No.
Let's say, okay, let's do this one first and then wait for the results. Will they do that?
No.
No, they will order a slew of tests. So they'll order CBC, chemistry, they'll order BNP, they'll order D-dimer. All right. So that's for the blood. Sometimes they'll wait for the D-dimer to come back. Sometimes if they really suspect, they look at the patient's risk factors. Oh, bedridden, smoker, has cancer. Okay, so they have one or more of the risk factors listed earlier in their chart 26-3. Yeah, so if they see those, they'll automatically send the patient for a CAT scan. Okay, so they say, oh, the score is so high, very high risk for PE. So they won't wait for the D-dimer, they'll send the patient for CT angio. Okay, so CT angiography, meaning that uses a dye, and they'll see if the patient has one or more clots in the pulmonary artery. However, what's the concern again? What could be a contraindication for that type of radiologic test? Because it uses a dye. Very good. If there's evidence of kidney injury, can they do that test? No. In that case, then they'll do a BQ scan instead, this one. So the test, so in addition to D-dimer, then we have the CAT scan, CT angio, which is the gold standard to diagnose a PE. If, however, the patient cannot do the arteriogram, the CT angio, then the only other option is the VQ scan. This stands for ventilation quotient scan, but another name is used. It's a ventilation perfusion scan. So they want to see, because the nature of the problem is blood went to the lungs, correct? But did all that blood come back with oxygen? No. And for those branches that were blocked, was that blood able to return at all? No, because they were obstructed, correct? So therefore, what happens to the forward blood flow volume? It will drop. So that's why we call it a ventilation perfusion mismatch, okay? So when they do the test, this is under nuclear medicine. So instead of using a dye to see which branches were blocked, they'll use a radioactive dye, radioactive gas. So they'll give the patient a mask, give the patient the radioactive gas to breathe, and then they'll take a picture. So instead of going through the IV to check where the obstruction is, they'll go through the lungs. So whichever part of the lung did not receive the dye, the radioactive gas, does not show the radioactive gas, then there's the obstruction. Okay, so they can go either way. Go through the IV, which we can't do again if there is kidney injury. Now let's go through the lungs. Okay, give the patient radioactive gas, see where the gas does not show up, there's the obstruction. Clear? Meaning we're trying to see the mismatch here. So there's adequate oxygenation, meaning no problem with the lungs. The patient's breathing in air, fine. The air is entering the alveoli. The problem is in the circulation side. Okay, one or more branches of the pulmonary arteries are not not giving blood flow because they were obstructed. Make sense? And of course, the D-dimer will also help. What is D-dimer again? We talked about this last semester under DIC. What is D-dimer? D-dimer is a... Okay, it is a...
That's made up one blood clot is dissolved.
Okay, it's a fibrin degradation product, right? So it's so clots are made of fibrin, correct? Okay, so what does the body do whenever a fibrin clot is formed? It will immediately start dissolving the clot. Okay, so fibrinolysis will occur. Once fibrinolysis occurs, meaning the body will break down the clot, what's left over is D-dimer. So therefore, if D-dimer is high on a patient, what does that mean? The patient has a lot of clots, right? The higher the number of clots. Make sense? Okay, so D-dimer, is it a good diagnostic tool? Yes. But we don't know though. If it's a D-dimer, we don't know if is this a DVT or a PE.
But it doesn't tell you what the clot is.
Exactly, but it gives you evidence, right, that there is clotting happening. Okay, so therefore, is it done alone?
No.
No, you still need the CT angio or the VQ scan. Make sense? Okay. All right.
Would they wait for the D-dimer to come back to then have to then?
Depending again on the patient's manifestations. Yeah. So if patient's symptoms are mild, they'll probably wait for the D-dimer. Then once the D-dimers come back high, then they'll discuss it among themselves. Okay, you think there's a high risk for PE? Then they'll score the patient. Okay, yeah, high risk, order a CAT scan. Right. Management is depending again, what category of PE does the patient have? So I mentioned the low risk PE, and then there's the submassive, and then there's the massive PE. So management. If the patient has a low risk PE, some of them aren't even admitted. So if a low risk PE, meaning that means it's a tiny clot, and the patient is otherwise stable, no major symptoms, no hemodynamic effects are seen. So the patient will be placed on a low molecular weight heparin and then sent home. The most they'll do is probably observe the patient for up to 23 hours in the ER. After that, they have no choice, send them home because they don't meet inpatient criteria. Because yeah, there's a PE, but then there's no symptoms. Okay, there's no shortness of breath, oxygen's good, blood pressure is good, no evidence of low perfusion, no need for oxygen, patient sent home. Okay, so that's for low risk PE. However, for submassive, patient has to be started on immediate anticoagulation. So let's go to the management under DVT because the management is here. Okay. Table 26-2. So the first thing they'll give is heparin, unfractionated heparin intravenously. So this will be started. The reason is this is how the heparin works. Binds to antithrombin, inactivates clotting factors 12, 10A, and has a half-life of 1 to 1.5 hours. All right. Because of its action, see, it inactivates clotting factors 12, 10A. Now, 10A is like the, if you picture the intrinsic pathway of the clotting cascade. So this is like in the middle. Okay, so when these risk clotting factors are activated, blah, 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 they meet at 10A. So at factor 10A formation, then they start activating thrombin. And then from prothrombin, then it will release thrombin, and then fibrin is formed. Okay, fibrin, of course, is the clot. Okay, fibrin will hold the clot, and there you have a solid, stable clot. So heparin stops it at it's antithrombin. So therefore, it prevents prothrombin from catalyzing into thrombin. So it immediately stops any clot. The problem here is, can you send this patient home on IV heparin? No. So the patient has to be on an oral anticoagulant, right? However, until then, the patient must be on heparin. So this is the first thing they'll give, and then monitor the dose. The dose is based on the PTT, right? So therefore, we draw PTT every 6 hours and then adjust the dose of the heparin based on the PTT. Okay, what's your question? Every 6 hours. Okay. Now, since it's an anticoagulant, does this do anything to the existing clot?
No.
So why are we treating it this way? This is a clot, but then we're not dissolving the clot. We're only preventing new clots from forming and also stabilizing the existing clot, right? Look at the action. It prevents extension of the clot and prevents new ones from forming. Why are we approaching it this way? I thought there was a clot.
Exactly.
And in stroke, we dissolve the clot. We gave alteplase. Why not do it here? Is there a need to? No, no need to, because is this patient stable?
Yes.
Otherwise, yes. Plus, is it dangerous to give alteplase?
Yes.
Yes, alteplase will cause bleeding, hemorrhage. So therefore, the best way here, because what will the body do to that clot anyway? The body will dissolve that anyway. Okay, so right now, is there an infarction? There is no infarction. There is no dead tissue here. The lungs are not dying. Okay, so therefore, the best approach is to stabilize whatever clots we have, prevent new ones from forming, and then let the body do its job. All right? Okay, so that's the purpose of the heparin.
But the patient had to not treat the patient for it.
We're not going to dissolve that clot. Because again, it's not causing any infarction anyway. It's not like a heart attack. It'll be a different story if it's a heart attack or a stroke. Remember? Stroke, we gave alteplase. Heart attack, we did cath lab, right? Catheterization and or even thrombolytic, right? We could give alteplase to a heart attack also. This one, there's no infarction. Does that make sense? Yeah, there's no infarction here. So therefore, the best goal would be, this is for submassive, okay? We're not talking about massive PE yet. We'll get to the massive PE later. So all we're doing is preventing that existing clots or clots from getting bigger. And also we don't want any new clots to form. That's the purpose of the heparin. Okay. And what's the dose based on? The PTT. Okay, so the higher the PTT, no, the higher the PTT, okay, the lower dose, the lower the PTT, the higher the dose. Okay, very good. Just making sure. What's the antidote? Protamine sulfate. Okay. All right. So this LMWH, low molecular weight heparin, is an option for which type, which category of a PE?
Is that massive? I mean,
Low risk. Okay, so this is for low risk. Okay, we can put a low risk PE on any low molecular weight heparin, enoxaparin, dalteparin. So you know these are subcutaneous injections. Okay. Now you'll notice that the dose is once or twice a day. In heparin, what's the half-life? 1 to 1.5 hours. It doesn't mention here, but low molecular weight heparin half-life is 12 hours. So that's why it's given twice a day. It has a longer half-life. So which one is better to use when we want to, let's say, we're planning to take the patient to surgery? Will you put them on low molecular weight or unfractionated heparin? Unfractionated, because 1 hour before surgery, we stop it, and then the patient can safely go surgery without risk for bleeding. Make sense? Okay. All right, the next one. These are now the oral. Now, the choice of which anticoagulant to oral anticoagulant to use depends on the doctor. Now, they look at the whole picture. Who is this patient? What does this patient look like? Is this patient going to be bedbound? Remember the risk earlier? So let me show you the risk. So here are the risk factors for PE. Remember the three: endothelial damage, venostasis, and hypercoagulability or altered coagulation. Okay. So they look at the patient. How old is this patient? What does this patient have? Okay, is this a cardiac patient? No, AFib, a flutter. No, what's causing the PE? Okay, what are the patient's risk factors and what is the likelihood that this will happen again? Are you following?
Mhm.
Okay, so the doctors decide based on what are these patient's risk factors. If the patient has no risk factor, so let's say none of these, okay, or let's say the only risk factor was the patient had surgery, they have hip replacement, all right, or knee replacement. That's what triggered the blood clot, and then they had a PE. So most likely, are they gonna be on anticoagulants forever?
No,
No, because is the surgery gonna be forever?
no.
No, this is only for a few months, right? So most likely the anticoagulation will be not warfarin. So they can use the, let's say, rivaroxaban, apixaban. I'll show you the names later. So they'll be on, those are called 10A inhibitors. But if the patient has some long-lasting risk factor for PE, let's say it's a heart condition, they have AFib, they have A-flutter, or they have heart failure, or spinal cord injury, blah, blah, blah. What else? Or valve replacement, for instance. The only choice there, if it's a valve problem, or if the patient has really high risk for, meaning the risk factors, the numbers are so high, the only choice there is warfarin. Okay, the best choice is warfarin. Especially if it's caused by a valve problem, okay? But non-valve problem and then lower risk, the patient can be on these ones. So these are the 10A inhibitors. So we've got rivaroxaban, apixaban, edoxaban, betrixaban. Does that make sense? Okay. So who gets these again?
No.
Yeah, lower risk
No.
and non-valvular. Okay, so non-valvular, no valve disorder problem. These are perfect. Okay, so this can be for long-term or short-term. Let's meaning 6 months or 1 year, and then we stop. Okay, so these are good. Benefit here is no diet restrictions, no vitamin K restriction, no blood work, also no monitoring. This does not affect PTT or PTINR. Okay, these are because there are 10A inhibitors. So very convenient. Fixed dose also. There's no need to weigh the patient. Okay, so you're not depending on PTT. There's a single dose for everybody. Okay, although they can raise, because let's say rivaroxaban comes in 5, 10, 15. So doctors can increase the dose sometimes, depending again on the risk factor. But very convenient to use. The problem is they also do not have antidotes. Right? The only one that has, one does have an antidote. I think it's apixaban. Let me make sure. No, I think it's dabigatran. Sorry, dabigatran has an antidote. All others do have no known antidotes. The best thing we can do for them is give them plasma, fresh frozen plasma. If they, let's say, come in bleeding because of these, the best thing we can do is give them plasma to stop the bleeding. But only dabigatran has a known antidote. So let's talk about warfarin. So how does, if the doctor chooses warfarin as the most appropriate anticoagulant for the patient, it is a vitamin K antagonist. What is the role of vitamin K in clotting? Factors 2, 7, 9, and 10 depend on vitamin K for production. Again, factors 2, 7, 9, and 10 are vitamin K dependent clotting factors. Meaning, if you inhibit vitamin K, the liver cannot produce these 4 clotting factors. Now, these 4 clotting factors are essential in the cascade. You don't have these, the cascade cannot, the clotting cascade cannot continue. And therefore, can they form a clot without these? No. So the vitamin K inhibitor, which is warfarin, will inhibit the production of these 4 clotting factors. Therefore, no blood clot, correct? And the monitoring is the PT-INR. Now, the problem with this drug is it will not work right away because when you take it today, it will only affect future clotting factor formation. Meaning, if I take it today I will stop making factors 2, 7, 9, and 10. However, do I already have these clotting factors in the plasma? Yes, they were made before I took the warfarin, right? They were made a few days ago. They were made last week. Okay, so now the problem is it's going to be a waiting game here. Warfarin will not reach its effect until about a week. It will vary. Some patients will reach the therapeutic goal in 3 days, 5 days, sometimes 7 days or more. We don't know. Each patient reacts differently to the drug. So it's a waiting game. So until we reach the target goal of whatever the doctor sets, typically if it's a DVT, the goal is 1.5 to 2. But if it's a PE, doctors typically want it between 2 and 3. If the patient has more than 1 episode of a PE, the target is even higher. It's going to be 3.5. All right. So therefore, until we reach the target INR on warfarin, the patient will be on heparin, this unfractionated heparin, and warfarin at the same time. Does that make sense? Why? Why is the patient on 2, heparin and warfarin, until the INR, target INR is reached? Why? What does heparin do again? It immediately provides anticoagulation. It immediately stops the formation of new ones and stabilizes the existing clots. Whereas warfarin, when does it do its job? Until later. Okay, it'll take time. We have to wait until the body gets rid of the clotting factors that are already circulating in the bloodstream. So it's a waiting game there. Could be 3 days, 5 days, 7 days.
For the heparin. No, for the
Warfarin. Again, heparin, when does the heparin occur? Does it take 3 days, 5 days? No, right now. When you give it to me, once I press start on that pump and it starts infusing, it does its job right now. It will prevent new clots from forming. It will prevent existing clots from getting bigger. Warfarin, however, how does it work?
The existing clot prevents further formation.
Talking about warfarin.
Okay. Yes, that's what you said, warfarin.
It's heparin.
No?
Does it say here? Here, I'm on the board. See, here's his textbook. Okay, that was heparin. So warfarin will, because warfarin is what? How does it work? It's a vitamin K inhibitor. So how does it prevent blood clots? By preventing the formation of factors 2, 7, 9, and 10. That's how it works. And how long does it take to do its job? 3, 5, 7 days, or sometimes longer. So until then, the patient must have both heparin and warfarin at the same time. Why again? Why 2? Isn't that too much? It's not too much because the one is working, this one is not working yet. Does that make sense?
Yes.
Okay. So that until the target number is reached, which is INR of between 2 and 3, or whatever the doctor set, patient must be on 2. Patients receiving IV heparin, patients also receiving warfarin once a day. All right. Any questions? Okay. Sometimes some nurses don't understand why 2. This is the reason. All right. Of course, what are your teachings for People on warfarin, what are those foods that are high in vitamin K? Okay, so we avoid those, right? Well, not really that you can't eat them. You can eat them, but not too much. So you have certain servings of them, okay? Because what's the antidote for warfarin? Vitamin K. Does it make sense you taking warfarin and then eating the antidote?
No.
Okay. Besides vitamin K as the antidote, fresh frozen plasma can also be the antidote. Okay. But sometimes the INR is so high and vitamin K can't stop the bleeding, so we have to give fresh frozen plasma. Why again? What does fresh frozen plasma contain? Clotting factors. All right. So the oral 10A inhibitors are given if what? If the patient, okay, non-valvular, meaning not caused by a heart valve problem. So these are good. All right. Very convenient. And of course, why are thrombolytics here? Okay, let's go to the massive PE now. Massive PE means there are not only multiple clots, but large ones. Clots are huge and they're blocking major branches of the pulmonary arteries. So therefore, what happens to forward blood flow? Significantly impaired. So the amount of blood returning to the left side, is it adequate?
No.
No. So therefore, is the patient stable?
No.
Is the patient having adequate cardiac output?
No.
No. So what type of shock is this? Cardiogenic is if there's a heart attack. Did the patient have a heart attack? No, the heart is completely normal here. Did the patient lose blood? Neurogenic is spinal cord injury.
Oh, yeah.
Something is blocking it.
Obstructive.
Just obstructive shock. All right. So a massive PE can lead to shock. So therefore, can we afford to give them anticoagulants only and wait and pray that the body dissolves the clot? No, they'll die. So we need to use thrombolytics. So we need to dissolve those clots right now. Of course, can these patients go into cardiac arrest?
Yeah.
Yes, they're in obstructive shock. They will go into cardiac arrest. So do CPR, you know CPR, right? And then BLS. And then once stable, we'll give the thrombolytic to dissolve the clot, watch them for bleeding, etc. Okay? That's for massive PE. Here's your teaching for patients on anticoagulants. Because after the thrombolytic, 24 hours later, because this patient, remember, if it's a massive PE, are their risk factors mild or significant? Quite significant. So are they going to be on anticoagulants forever? Yes, they're lucky they survived the massive PE. So they have to be on anticoagulants. So they'll be on, depends again, either 10A inhibitors or warfarin, all right? Depending on the underlying cause. So here are your teachings. So any patient on anticoagulant should be aware of what type of anticoagulant they're using. And if it's warfarin, obviously you teach them about vitamin K restrictions. Never stop the drug, even if, let's say, there's evidence of bleeding. Okay, let's say they have a nosebleed, they see blood in their urine. Because remember, if they stop, yes, they'll stop the bleeding, but then meanwhile, did they get rid of the anticoagulation requirement? Meaning, did the valve disorder disappear? Did the AFib disappear? Did the A flutter disappear? No, the risk remains. So do they need anticoagulation? Yes, they continue to need it. However, because they're bleeding, does that mean they can independently stop the bleeding? Stop the drug? No, you tell them do not stop for whatever reason. So if they're bleeding, what should they be told to do? just lay down and curl up? No. So they'll be told to call 911. Okay, but do not stop whatsoever. Do not stop the anticoagulant until told to. Are we clear? Right. Because the safe thing to do is, remember that there's a reason, right? Why are they taking anticoagulants? Because they have a risk for a PE or a stroke or whatever. Does that disappear when they bleed? No, they still need the anticoagulation. However, because they're bleeding, they need to go to the hospital. And what do you think will be the treatment? They're bleeding, but then they also need anticoagulation. What drug would be perfect for this condition? Has a short half-life. Unfractionated heparin. Warfarin has the longest half-life in all of these anticoagulants. Okay, so the shortest is heparin. So you can simply start a low-dose heparin IV, stop it if there's evidence of bleeding. Remember, 60 to 90 minutes only. So read the rest of these. I won't read them for you. Here, especially the evidence or signs and symptoms of bleeding. Okay, they need to know that. Okay, so any question about PE? Okay, let's go to the last two. Let's go back to respiratory chapter under this is upper. Let's go here. Let's go to respiratory failure. This is short. What is respiratory failure? This is a state or a condition. Okay, so nobody comes in with just this diagnosis. Again, nobody comes in with a single diagnosis of acute respiratory failure. There is a long list of causes, meaning there is a long list of primary diagnosis, and then they will just add respiratory failure to it. Okay, let me explain. So because it's a state, it's a condition, you meet this state or condition if there are three things here. If we'll draw ABGs, and then that ABG shows that your PaO2 is less than 60, your PaCO2 is more than 50, and your pH is less than 7.35. And of course, when your numbers are here, is your oxygen saturation above 90?
No.
No, I mean, PaO2 less than 60, there's no way your oxygen saturation could reach 90, correct? Again, I repeat, you are in respiratory failure, regardless of the cause, if your ABG shows a PaO2 of less than 60, a PaCO2 of over 50, and a pH of less than 7.35. You are in respiratory failure. So what are the causes of this? These are the, there's no table. Okay, so here are the causes. So just grab them from the paragraph. So these are the causes. You'll notice that some are respiratory, meaning lung conditions, but most are not. Example, you overdose on opioids or whatever you OD'd on. Respiratory rate drops. Will it cause those symptoms in the ABG, those numbers? Yes. You have head trauma.
Yeah.
What happens to your respiratory rate when you have head trauma? It drops, right? Okay. You have sepsis. Does that lead to shock? What happens to oxygen there? Also drops, right? Okay. So sepsis or any shock can lead to respiratory failure. Hemorrhage, same? Yeah, because blood carries oxygen. You don't have enough RBCs to carry that oxygen, causes respiratory failure. Sleep apnea. No, obstructive sleep apnea because you're not breathing enough, right? You stop breathing during the night. So what happens to your oxygen levels? It drops, yeah. Okay. So here, myasthenia gravis. What happens to the rate and depth of respiration? Decreases. So what happens to oxygen levels?
No.
Okay, so I could go on. See? There's an endless list of conditions that can lead to respiratory failure. Do you follow so far? So is respiratory exclusively a lung condition?
No.
No, it is rather a complication from various pulmonary and non-pulmonary causes. Are we clear? So these are what do all of these things have in common? What did they do to the respiratory rate and depth?
No.
They decreased it. So they either decreased the respiratory rate or they decrease the respiratory effort, meaning the patient is breathing shallow, correct? So does that occur with pain? Here, chest trauma, you're in pain. Yeah. What about, let's say, obesity? Yes. Or let's say you're making love to someone who is obese and you're in the bottom, and that causes respiratory failure. Yes. Okay. So again, endless causes. Okay. So either a mechanical or physiologic cause that will result in a decreased rate and depth of your respiration leads to respiratory failure. There's two forms, acute or chronic. Obviously, which one are we concerned about? The acute. The chronic respiratory failure are pretty much stable patients. I mean, they're abnormal, but they're not likely to die right away. Okay, so there are two types here. We have oxygenation and hypercapnic oxygenation failure, a respiratory failure. Oxygenation meaning it's a gas exchange problem. Let's say pneumonia can lead to respiratory failure as well. When it's hypercapnic, so it's any condition that will increase CO2 levels, which means oxygen levels are also low, correct? Because it can't be both high or both low. So either oxygen's high and CO2 is low or vice versa, correct? Okay. Manifestations, nothing specific. So including the manifestations of the underlying cause that led to the respiratory failure, plus what will someone with an ABG of PaO2 less than 60, PaCO2 over 50, and pH of less than 7.35 look like? Are they gasping for air? Yes, so they'll be respiratory distress. They'll have cyanosis. What will happen to the color of the nail beds? Okay, bluish, and then the face will look dusky, correct? Yeah, so nothing specific, nothing exclusive. So when you look at them, respiratory distress, okay, having shallow breathing, okay, gasping for air, respiratory failure. Okay. Of course, the diagnosis is simply based on the ABG. Okay, so they make the diagnosis of respiratory failure on what do the ABG look like. So what does the ABG look like again in respiratory failure? pH less than 7.35, 50, and O2
More than 50. PaCO2
less than 60. All right, very good, children. The management is simple. Oxygen. Would you agree?
Yes.
Yeah. Oxygen therapy, just for the respiratory failure, okay? So we give them oxygen. Of course, what led to the respiratory failure? These conditions right here we just discussed. Okay, so all of these have to be treated, correct? So if you don't treat these, will you ever resolve the respiratory failure? No. Understood?
But immediate treatment is oxygenation.
Oxygen first, right? Because look at these causes here. Are they easy to manage?
No.
Look at kyphoscoliosis. You have to do surgery. You have to fix that. Okay, kyphoscoliosis is like this. So my spine is curved like this. Plus, it's also curved like this. I'm like this. Can you fix that right away? No. So the only immediate treatment is oxygen. However you do that, let's say mask, nasal cannula, or intubate the patient. Okay, so however you meet to correct the ABG, the PaO2 must be over 80, or at least 80, CO2 45 or less, and then of course pH between 735 and 745. All right, so that's how you fix respiratory failure. Oxygen until you fix the underlying cause, which is not easy most of the time, right?
We did a doctor's order for 2 liters user panel.
For any oxygen, yes.
Because some people
Any.
say that you don't like if it's
No, it's not like that, okay? Meaning you can give it
Then get a.
without the doctor's order and then later get it. Okay.
You cannot wait for the doctor.
Yeah, I mean, meanwhile, the doctor's in the barber shop not answering the call. So what your patient gonna do? Sorry, the doctor's not answering. And then patient's gasping, not giving any oxygen. Make sense? All right. So here are the manifestations again, non-specific, not exclusive to respiratory failure. So it's anyone with respiratory distress, having retractions, respiratory distress. Management again is oxygen. So we'll discuss the intubation and mechanical ventilation next week after the third exam. Okay, let's finish so I'll cover the endotracheal intubation, etc. Next week, okay? So let's finish up the day and the coverage for the exam on ARDS. Let's go to acute respiratory distress syndrome. This is also very short. Okay, we can do this in 10 minutes or less. So what is ARDS? It is respiratory failure. It is a progressive form of respiratory failure because it's respiratory failure as well. So what does the ABG look like? This is respiratory failure. So what does the ABG look like? 7, be specific. 7, what's the pH? 7.35? That's normal.
I mean,
Less
when you
than-
guys say-
Less than 7.35. What's the PaO2?
more than 40.
PaO2.
Less
Less than 60. What's the PaCO2?
That's higher than 45.
More than 50. Okay, so it is respiratory failure. However, what makes it ARDS and not respiratory failure? Here, the cause is acute lung injury. And we'll look at the causes, what causes acute lung injury later. But this is in addition to the respiratory failure ABG. The patient on X-ray has water in the lungs. Diffuse bilateral infiltrates. Both lungs look white on X-ray. Are lungs supposed to be white? Supposed to be black on X-ray, right? Because are they supposed to contain water or air? Supposed to contain air. But here, why are they containing water? Okay, we'll explain later. Hypoxemia, unresponsive to oxygen. The term here is refractory hypoxemia. Again, hypoxemia unresponsive to oxygen is called refractory hypoxemia. Why are the lungs not responding to oxygen? Is it possible to have gas exchange if the lungs are wet? No. How can gas exchange occur? Can you fart into the pool? Can you fart while you're in the pool? Haven't you done that before? Yes. Yeah.
And the little bubbles
You
walk.
can. Yeah. Yeah, she's an expert. She knows exactly. No, she's had quite an experience already. So it gets caught in your swimming trunks first, right? Yeah,
Mhm.
gets caught in your bathing suit first, and then you loosen up a little bit, and then it'll go up, right? Okay. However, if you're above the pool, let's say on the ledge, can you fart into the pool?
No.
So therefore, can gas exchange occur when the lungs are wet? No. So that's the second. So the patient's X-ray looks white. You give them oxygen, no effect. Oxygen, no matter how many gallons you give of oxygen, it does not improve the oxygenation. Because why? The lungs are wet. Okay. Now, when you insert a pulmonary artery catheter in these patients and measure the pressures inside the heart, it's normal or sometimes even low. Again, when you measure the pulmonary artery pressures, they're normal or low. Because does heart failure cause pulmonary edema?
Yes.
Yes. This is therefore a non-cardiac pulmonary edema. Those white lungs you see is literally pulmonary edema, correct? But it's non-cardiac in nature, meaning the heart did not cause that water to enter the lungs. So therefore, the heart measurements will be normal or even sometimes low. The pressures inside the heart, right? Because it's a non-cardiac pulmonary edema. As a result, if the lungs are wet, are they compliant? Are they going to stretch and recoil? No, they can't if they're wet. They're supposed to be dry in order to do that. That is ARDS. What are the risk factors? Look at the causes. Are they lung related? Some are. Let's say aspiration. So yeah, that's so basically how I would name this chart is causes of acute lung injury. Remember, it mentions here acute lung injury. Okay. So do you think each one of these will injure the lung? Look at that. Aspiration. You aspirated, no, you let's say you drunk. You ate tacos, hot sauce, had beer, had tequila, and then you vomited, and then all those contents went into your lungs. What will that do to your lungs? Will it injure it? Yes. Pneumonia, COVID pneumonia. Yes, of course, that will injure the lung. Drug ingestion and overdose. Again, this one is related to, so what happens when, how does your body react to this? Is that gonna cause, because let me explain acute lung injury. When we say acute lung injury, the capillaries become leaky. Remember sepsis and septic shock? We talked about this. Okay, so therefore, acute lung injury, ARDS, is a result of sepsis, right? Severe sepsis. Remember, they go into ARDS and DIC. So here is ARDS now. So it resulted from the same exact mechanism that caused or happened in severe sepsis. So the capillaries became leaky. And imagine the alveoli. We have 100 million alveoli. If each one of those capillaries wrapping the alveolus become leaky, where will that water go? Into the alveoli. Okay, so that's where the water came from. It's not because of heart failure. It's not because of congestion. It's because of capillary leak, because of acute lung injury. Okay, so here's your long list. All of these, are these minor conditions? Or are these serious injuries? These are serious diseases and injuries. So this will trigger acute lung injury. And the acute lung injury, unfortunately, does not stay local. So the capillary leaking, yes, it will start at the alveoli first, but then the entire body eventually will have the same reaction. The entire body, every capillary in your eyes, in your brain, in your toes, in your legs will become leaky. So this water here leaking in the alveoli will begin happening everywhere else eventually. So is ARDS nice? Is it easy to treat? No, because again, just like acute respiratory failure, how is this treated? How do you manage ARDS? The patient is in ARDS. What do you do? Because there's no, well, the chest tube, if it's a pneumothorax, if it's in the pleura, is the fluid in the pleura? They're in the alveoli, and alveoli are individual sacs. Don't tell me you're going to put a chest tube in each microscopic alveolus. 100 million chest tubes. No, impossible. Okay, so is it easy to treat? No. Okay. Yeah, so and then is it easy to treat these? So therefore, is ARDS a good prognosis? No, it has a 50% mortality rate.
Wow.
What year is it now? 2023. The mortality rate before the World War was already 50%. Did we make any advances? No. There's nothing we can do with this. So this is just an unfortunate self-destructive reaction by our body to something severe, to a severe injury or insult. Yeah. So once we have acute lung injury, this one, we can't stop this. Okay, this is how our body reacts to these. So burns, for instance, or fat embolism, major trauma, sepsis, COVID, this is how the body reacts. Okay, the body panics. Okay, and then they panic, they react by causing capillaries to leak. They release so much histamines, anti-inflammatory substances, and then they cause as a result, the capillaries leak. Okay, and then the capillaries in the alveoli, of course, leak water, drowning the alveoli. And unfortunately, again, we can't stop that reaction. There's no drug, there's nothing we can do to stop the reaction. So therefore, how do we manage ARDS? How did we manage respiratory failure?
Oxygen.
Oxygen, same thing. It's the only thing you can do. However, can you give this oxygen nasal cannula or a mask, a BiPAP? No. These patients will have to be intubated. Intubated, put on a mechanical ventilator, and force the air into the alveoli. So we'll discuss the mechanical ventilation next week. So how will mechanical ventilation help? Remember, the fluids came from the alveoli, correct? So let's say this is my alveoli. It's wrapped by a capillary, correct? That's where gas exchange will occur. And each one of those capillaries are leaking fluid. That's why they enter the alveoli, the air sac. So now if I force the air using positive pressure, I give the patient an artificial airway, put a plastic airway inside, turn on the ventilator. The ventilator will forcefully deliver air under high pressure. Will it push the water out of the alveoli and back into the capillary?
Yeah.
Yes. However, when the ventilator stops giving the breath, what will happen to
Go back.
it will go right back in. You see the nature? So because the capillaries are leaky, they will leak fluid into the alveoli. However, if I force air, yes, I'll get rid of that water momentarily, pushing it back into the alveoli. However, because the alveoli, pushing them back into the capillaries. However, because the capillaries are leaking, what will they hold on to the water after it's pushed back in? They will leak it right back out. But for that moment, a few seconds, 1 or 2 seconds, did I accomplish gas exchange? Yes. Will my patient stay alive? Yes, until we resolve whatever led to the ARDS. Okay, until we get rid of the pneumonia, the sepsis, etc. So it's going to be a long road. Okay? Any questions on ARDS?
No. That's it.